Today I'm delighted to welcome Professor Jerome Pereira, not only a dear and very loved family friend, but a global leader in oncoplastic breast surgery and medical education from the UK. Hello, welcome.
Thank you for that kind welcome.
Professor Pereira is a consultant oncoplastic breast surgeon at James Paget University Hospitals Foundation Trust and the founder of Program Director of Blended Learning UK. Blended Learning UK, in collaboration with the Association of Breast Surgery, have recently won a major grant from Global Health Partnership and Sanofi to deliver global breast cancer training package to improve early detection and survival in the sub-Sahara Africa. Congratulations.
Thank you.
Through the University of East Anglia, he leads internationally recognized membership and master's program, training clinicians from over 70 countries over the world. He is the originator and lead surgeon of the UK National Mastectomy and Breast Reconstruction Audit, the world's first national study of its kind, which led to the publication of best practices, national guidelines for oncoplastic breast surgery. That's wonderful. What an achievement.
Thank you, Lalit.
With over 300 invited lectures and a career devoted to improving patient outcomes through education and innovation, Professor Pereira brings a powerful global perspective to today's conversation. Today, with Dr. Pereira, we discuss the very important patient-reported outcomes, training and improving of the quality of life and care of patients. I think this topic has hardly been touched upon because most of the time people think about the treatment, the surgery, the chemo, the radiation, and they don't realize that's only over 6 months or a year, and what happens to the patient for the next 30, 40 years that she's living and what happens to her. So my first question to you, Professor, is what exactly are patient-related outcome measures, PROMs, it's known as, and why should patients care about them?
I think traditionally, as surgeons, we were very, very single-minded in the way we looked at patients and looked at our own results. And
Right.
When I was growing up as a surgeon, there used to be a common saying, "In my hands, patients do well." And that is a combination of arrogance and ignorance.
Yes.
And many, many years ago, about 30 years ago, in fact, I had the privilege of being a researcher at the Royal College of Surgeons of England. And my project was to try and develop a innovation in terms of improving patient outcomes in leprosy.
Oh,
Very, very strict.
and that is so important because
Very
they're
important.
mutilated.
Because leprosy patients are mutilated, their faces are damaged, hands are damaged.
Deformed.
And my thesis was on the development of a new operation, a reconstructive operation to restore sensation in leprosy. And the loss of sensation was the reason why patients lost their fingers and damaged themselves.
Yes.
And I was privileged to develop a new operation that was the only operation, it still remains the only operation that produces protective sensation leprosy. Now, when I took my results to different parts of the world, because I was operating on patients in India, I was operating on patients in Brazil, in Ethiopia, all these patients were saying, after the operation, I could feel heat from the oven, I could feel thorns, I could feel the pain. But the nerve conduction studies, scientific studies, did not show any signal. And therefore, at scientific conferences, I was knocked down because I was not producing objective data.
Objective data.
And that taught me a very, very important lesson, that you must listen to patients. Surely patients in different parts of the world can't say, who are separated by thousands of miles in different languages, say the same thing. And clinicians could not take the word. And therefore, when I started doing breast surgery, I was one of the first surgeons in the United Kingdom to start doing immediate breast reconstruction. And I was conscious that it's important to know what patients felt about my operations. And therefore, I started, what I didn't know was PROMs. With my first major reconstruction, I gave the patients a questionnaire saying, how much pain did you have? How comfortable did you feel with your surgeon? How confident do you feel after the operation? Would you Would you recommend this operation to another friend of yours? How confident do you feel, dressed, undressed, etc.? So with the first patient, I started a questionnaire, not only looking at the patient's surgical outcomes, but also patient-related outcomes. And that, what I mean by PROMs, is patient-related outcome measures that gives us patients' views on their satisfaction with the surgery and how the surgery has affected the quality of their lives.
My God, this is phenomenal because it's so important, especially in India. I find maybe 90% of the surgeons don't address this issue. It could be cardiac, it could be cancer, it could be, orthopedic surgery, anything. The patients are left to find out and fend for themselves later. And they don't even know what to look out for, what is coming later. I myself had a cardiac surgery last year, and I myself was searching on the net for so many things. I had hot flushes, I had hot sweats at night. There were no answers. And I think it's so important to be able to record this and to help other patients go through what they have gone through, right?
Yes, I was very fortunate that the United Kingdom, the government funded this project from the basis of my personal audit, which I extended to a region to include Cambridge and other hospitals. And then the data from that gave confidence to the government to help us to run a national, the first largest study in the world. We looked at 18,000 patients prospectively.
That's wonderful, isn't it?
And yes, and out of that, we found some amazing, surprising, and sometimes very painful
For
data. For example, a significant number of our patients undergoing breast reconstruction, in other words, 20% of our patients were in severe pain.
Oh.
So our pain control was not good.
Good. Pain management.
More than 40% of the patients undergoing mastectomy felt they had inadequate information about reconstruction because that could have informed
yes,
decision
and they could have
about
made the different choices.
An immediate reconstruction. So a huge number of data came out. For instance, we had a higher infection rate than we thought we had. We had a high implant loss rate. So a number of factors came at the forefront, which enabled the production of a best practice guidelines.
Isn't that data priceless?
Absolutely.
It's really
and
priceless.
It's very, very important what the patients told us, because that has informed our practice in the UK, and also it's very, very powerful data for policymakers and also for surgeons. But despite the fact that we have this data there, we still have pockets of poor practice in the United Kingdom. So don't think we've got it all right there.
No, I'm sure.
Data is one thing. Information is one thing, but the application of real data into clinical practice is still a challenge.
Still a challenge. I'm sure it is. It is all over.
Yeah.
Beyond cure, what outcomes, Professor, mattered most to patient after breast cancer treatment? Do you think? What are the outcomes that matter most?
I think when you tell a patient you've got breast cancer, you are altering their lives permanently. Just one sentence out of your mouth. And therefore, it's very, very important that you look at the patient as a whole. And as I was commenting today on one of my colleagues' lectures today,
yes.
We have pushed the boundaries in restoring body image by giving patients a rebuilt breast immediately,
yes,
and oncoplastic breast surgery, again trying to restore body shape. But there is that element of the patient's own psyche. And it takes more than just physical. And I think we have to, in many ways, congratulate ourselves by identifying that there is such a thing as survivorship. But I think we are now entering into a phase that, apart from improving our surgical techniques and aesthetic outcomes, we have to look at the patient as a whole and look at the whole psychological impact. Though this work has been done, but nobody's come up with solutions. And I think we really need to there's a huge amount of development in the world of psychotherapy.
Yes.
And, improving cognitive function, improving pathways. There are a huge amount of work going on. And if we can bring that in to patients, then we will do them a better service.
Yeah, it's like I often say, it's when there's a disease, any disease is about treating the patient, not the disease.
Absolutely.
So that is very, very important.
Absolutely, yes.
Professor, how do you find listening to your patients' feedback improves the surgical or the overall cancer care for the patient or for the other patients?
Yeah, I think it's valuable data. In fact, in our hospital, our breast care nurses are very good at gathering data and from our patients, and we do intermittently, do these PROMS data, or some of our trainees are very good. So particularly if you got a new oncoplastic operation, for instance, the modified lag cap operation, which one of our colleagues introduced, which I started undertaking in the United Kingdom many years ago. And we said, let us look at what the outcomes are. So we looked at the first 40 operations, and particularly in terms of PROMs, patient-led, what do you patients feel about it? And some of them came and said, actually, I find the scars a bit tight. So sometimes there could be a little a dip in the breast. So we started. So on the basis of that, I altered the operation. On the basis of that factor, I looked at my scar placement, and I looked at also how to reshape the breast when I am undertaking the operation.
Yeah, because if the scar's too tight, they always feel that pull or push when they're sleeping on a particular side. It stretches, or there's a burning sensation or something.
Absolutely, yes.
Why do you think quality of life is such an important outcome in today's breast cancer treatment?
I mean, I think many years ago, if patients survived cancer, they were relieved. And now that, a good 90% or 85-90%, certainly in the Western setting, patients are surviving breast cancer.
Yes.
And there is life after breast cancer. So if you think a patient has got 30 or 40 years of living after a diagnosis of breast cancer, then that quality of life is important because, for instance, patients will say to you, doctor, after a mastectomy, I feel terrible every time I lift my child up because there is nothing there between my child and my chest. So there are, and I think it's very, very important to look at the patient as a whole. So it's an ongoing challenge, and I think, but it's good that we are living in the days and we are able to discuss these issues. But apart from the goodwill to make changes, resources are important.
Yeah, most important.
That is
resources.
the challenge we have got.
Exactly.
We know PROMS is important, but who's going to
do it and
who's
fund
going
it and
to
everything?
fund it?
Absolutely.
Who's going to collect the data? So
There
are a number of issues that are currently a challenge, but we need to not be defeated by it.
But at the same time, if it's possible, then a structured training program would definitely improve the patient's satisfaction and outcome, right?
Yes, I think education, one of the reasons why I went into the education field is because this audit. You asked me how did a patient PROMs affect impact, change. I noted that there was a variation in outcomes among practicing surgeons in the United Kingdom from this audit. Some surgeons had good results. Some surgeons provided a very narrow range of operations. And I felt there was a need for extra training. And that's the reason I started the first Master's in Oncoplastic Breast Surgery 15 years ago at the University of East Anglia. And with the sole aim of augmenting the national training in order to improve patient outcomes. And that little did I realize that you and I would be sitting here because the reason I connected with you and Anand is because of a common interest in improving patient outcomes.
You have been, Professor Jerome, a master and a pioneer in global training, if I could say so. You have brought that training to India, your master's course, and I think hundreds of surgeons have passed through this course and have received their masters. I think many of them are getting their certification today also. They're going to be honored. So what is the lesson that you would have learned or realistically found from this global training, which could be more applied to India? Where is the need in India that you feel that vacuum that's missing,
Yes, I think in India, when I joined forces with Anand to start the training in India, I remember the first conference we had here.
Yes, absolutely.
I think about 13 years ago. And the among the group of attendees, the knowledge of oncoplastic breast surgery was virtually
zero. And today, look at
and today, I am amazed at the quality of the presentations, the enthusiasm, and the range of treatments, operations that are provided by surgeons who you and Anand have, been pivotal in starting along with ourselves at the University of East Anglia. So the lessons I've learned is actually you can make a difference when you meet the right people. You can, if you get the right, people are passionate in wanting to do something for patients, and their focus is only patient care, nothing else. Single-handedly focus on patient care, then anything is possible. And today's conference is a living testament to that.
Yes, I remember 13 years ago when you all had the first conference here jointly with you and us.
Yes.
And the word oncoplasty and reconstruction, especially oncoplasty, was a naive word. Many surgeons didn't know. No. Many doctors didn't know what it meant. And I think Anand, as in Dr. Kopikar, fondly known as the father of oncoplasty in India, along with Professor Jerome Pereira, they merged into a beautiful marriage to bring this course of his to India. And because of this course that Dr. Jerome Pereira brought to India, hundreds of surgeons for oncoplasty have come out, and many women have benefited with breast cancer. They've not lost their breasts. They've had their breasts reconstructed, and they have a better quality of life today because of that.
I think it's teamwork. I mean, the right people, and you and Anand, you have built an amazing team, and your dynamism and dedication shows for itself.
Thank you. Professor, I think better education among healthcare professionals translates to better patient outcomes. What do you think?
Definitely. That's one area, actually. I mean, we have been talking about our training programs for surgeons, but I have had the privilege of extending surgical training programs to all aspects of breast cancer surgery. So I think we are probably one of the only centers in the world in United Kingdom where we are providing training for breast ultrasound, for breast care nurses, for general practitioners, for PAs, for radiographers. So we bring training across the whole spectrum. And now we have extended our training globally. I mean, we had already extended it through the masters.
Professor, would you say better education among healthcare providers and professionals translate to better patient outcomes?
I've been in education and training for the last 30 years.
Yes.
And I have no doubt that better education produces better outcomes. And we have got data to prove that. From the outcomes of our master's programs. One of our research fellows undertook the outcomes of our master's programs just in one of them, in the oncoplastic breast surgery program. And he identified something like a 95% improvement in the confidence levels, improvement in the decision-making, reduction in mastectomy rates. So a number of factors. So we've got hard data to show that education improves outcomes. But the other interesting experience I have is that in association with the breast cancer group in UK, the Association of Breast Surgeons of UK, Blended Learning UK have combined forces to start this education training program across sub-Saharan Africa.
Wonderful.
We were delighted to win an international award to train from the level of the master trainers in each country. So we've got 2 pilot sites, one in Zambia and one in Uganda. We started working with the ministries of health and the cancer specialists in each country, and then we cascade the training down to the primary care workers and the community health workers.
Fantastic.
The idea being that training, raising the awareness, training in breast self-examination, and then disseminating this to the general public. So we started this program last year, and over the last 6 months, we have trained 1,200 nurses and community health workers who have reached above 150,000 general public already in the last 4 months.
Very nice. It's the need of the hour.
And now we are already picking up cancer.
It's the need of the hour.
Yes.
You know, the saving lives, basically.
Saving lives, yes.
I'm myself very, very passionate about awareness and early detection. And I feel the earlier you pick up breast cancer, it's complete pure survival.
Yeah.
And don't you agree that plays a huge role in the survival of the patient? You know?
And Lala, this program is piloted. We will have the outcome results in end of next year. And the plan would be to roll out the program across
the world.
my throat, sorry.
Yes. That's okay.
Yeah. So we plan to,
Yes.
with the results of the pilot study, we plan to roll it out across the low and middle income
That's
countries.
the most important because that's where you can pick up the early cancers, and they're
Absolutely.
completely unaware of a self-breast examination or signs or symptoms or anything.
Yeah. Sadly, 50% of our patients in many of the lower and middle income countries are dying of breast cancer.
Yes.
While in the West, only 1 in 10 will die from breast cancer. So it is a major, major problem. And when you think 2.3 million patients every year are being diagnosed with breast cancer globally. So it is a major, major
Big,
problem.
huge loss of life.
Challenge, yes.
Absolutely. In your opinion, what should a patient expect or demand from a highly qualified breast cancer pathway? What should the patient be informed?
I think the patient should expect, firstly, the healthcare professionals to treat them with respect. The patient should expect to be listened to, and the communication of the specialist should be at a level that the patient has got a full understanding. I think when a patient walks in to a consultation, the patient should be expected to be treated with respect. And the carers, healthcare professionals, should show empathy and care, and also make the patient comfortable and feel that they're being listened to. It's vitally important. When the healthcare professional communicates with the patient, it is his or her responsibility to make sure that the patient is receiving the message. Patients should be empowered in terms of being given enough knowledge to make the right decisions for themselves. So the right to be involved in decision making regarding their own bodies and the treatment is vitally and centrally important to everything we do. Secondly, it's important that the healthcare professional has got a multidisciplinary team around them, so that a surgeon, an oncologist, a radiologist, a breast care nurse, all are there to support the patient, and the joint decision making focused entirely on the best optimal treatment for the patient comes through in that.
So true, Jerome. I think when a patient is heard and they feel there's empathy, and they feel they can share openly with their doctor what their feelings are, and there is a reciprocation.
Yes.
The patient heals faster.
Absolutely.
Those patients do much better. They get back to normal life much earlier, and they heal much faster.
Yes.
On a closing note, I'm very, very interested to hear more about your African subcontinent program and what have been your learnings from it.
I must say before, the African subcontinent program there are a number of people involved in it. I got, as Executive Director of Blended Learning UK, I've signed the agreement with Sanofi and Global Health Program and ABS. But the two colleagues in the UK who are leading it, Sudan, my colleague Sudan, Professor Sudan, and Ruth.
It's a teamwork.
It's a team. Okay,
yes,
it's a team. It's a teamwork.
It's
okay.
Teamwork.
So what do I get from it? I think the joy of being able to impart our experience into a much needed environment where there's real potential to promote early detection of breast cancer, leading to earlier diagnosis and early treatment. So that is a privilege and honor to be involved in it.
And there's so many lives being saved in the bargain, and it's a cascading program that will go into different countries in different areas, and inevitably it's a matter of time that there will be a standard uniformity of protocol being maintained.
Yes,
and you will set that protocol over the years.
I mean, there will be a lot of people coming after me, I'm sure, because this is a massive program, as you know. And but I think it's good, and certainly we would like to bring this awareness to India, work with groups, because we are collaborative by nature, as you know.
Be very happy to.
And I think anybody who wants to join with us to take the message across to pockets of India, which require this kind of service, will be great.
Thank you so much for being here today with me.
Thank you.
I hope you enjoy the rest of your stay in India.
Thank you.
Thank you very much.
Thank you.
Thank you.